Through innovation, academic excellence, and family-centered clinical care, Children's Mercy Kansas City is transforming outcomes for children around the world. Welcome to the audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
Welcome to Transformational Pediatrics. I'm Dr. Michael Smith, and our topic is the impact of genetics on statin disposition and response. My guest is Jon Wagner. Dr. Wagner is a pediatric cardiologist at Children's Mercy and an assistant professor of pediatrics with the University of Missouri-Kansas City School of Medicine. Dr. Wagner, welcome to the show.
Thank you very much for having me.
So, approximately how many adolescents with dyslipidemia are eligible for pharmacological treatment?
So I think that's a very good question. We are starting to see with several observational studies over the last few years that more and more children are at the cut points to qualify for statin therapy. That actual number is anywhere from 200,000 to 400,000 adolescents based off the studies that were previously done. So that is a large segment of our population in the U.S. that would currently qualify for statin therapy. And I think that it's really important to, with that increasing number, to really understand how the statins are working in the pediatric population. I think that,
and what about the increasing prevalence of overweight children? How is that impacting these numbers, do you think?
Exactly. It's hard to tell what the actual baseline was for children that would qualify for statin medications, because really the observational studies have really been started after the year 2000 and really in this new millennium. I think that those numbers will continue to rise because twofold. Number one, we're screening patients more effectively in the United States than what we previously had done. The NHLBI and American Academy of Pediatrics, American Heart Association, now recommend universal lipid screening on every patient 9 to 11 years of age, and then again in late adolescence to 17, 21 years of age. So we are discovering more patients that have asymptomatic dyslipidemia that are otherwise healthy patients. The other big reason is the trend towards childhood obesity in our country. A third of adolescents now are defined as overweight, and with that trend, we're seeing more patients that are at risk for coronary problems later on in life, and dyslipidemia is a major cause of that.
Do you, when it comes to adolescents and when it comes to measuring the lipid profiles, are the pediatric population, or are you guys going more into some of the more advanced, lipid analysis, not just the standard total cholesterol, LDL? I mean, are you guys actually breaking down the LDL subtypes? Are you doing more advanced testing in kids?
At this point, I don't think we've done as much in terms of the advanced testing like our adult counterparts. There are some pediatric centers across the country that are subtyping the lipid profile to a greater extent. I think at this point it's more of a research endeavor as opposed to the actual clinical implications. But I think it's important to appreciate that because that may refine our guidelines for the future in the pediatric population.
And what about, when pediatricians are speaking to their patients and the family, what about having that conversation about sugar intake, right? I mean, how important is that conversation to this whole dyslipidemia conversation?
Absolutely. I think the two are very much linked in the sense of what we've already described about the increasing overweight adolescent population in the United States. The harm of a poor diet not only can accelerate the atherosclerotic process, not necessarily in childhood, but in young adulthood. but it can also lead the patient potentially at risk for other comorbidities, more specifically diabetes. And we know that when those two disease processes are linked, meaning the dyslipidemia and diabetes, it places the patient in an extreme risk of having a coronary intervention very early on in life.
Right. Tell us about the cardiology pharmacogenomics repository that's been established at Children's Mercy Kansas City.
Absolutely. The cardiology pharmacogenomics repository, kind of conveniently named the CPR, is our acronym, and we hope to prevent CPR by really this type of preventive treatment later on in life. But I developed this biorepository at our institution during my cardiology fellowship training and clinical pharmacology training. The purpose of this repository is really to collect biospecimens and eventually isolate the DNA on patients that are seen in a number of our clinics, our cardiology preventive clinic, our weight management clinics, our endocrine clinics, and nutrition clinics. Any patient that's really at risk of cardiovascular disease can be enrolled in this biorepository. Once we have isolated the DNA, we're able then to run genotype analysis on anything that we're really interested in related to cardiovascular therapeutics. What we have targeted so far in the biorepository is a specific genotype, and that is a gene called SLCO1B1. This gene is responsible for basically laying the framework for a liver-specific protein that takes statin medications from the blood into the liver, and that's where statins work. So the purpose of the biorepository is really for that DNA, so we can run that genetic testing, but it's also a kind of living, breathing patient registry by which we identify gene variants or patients that don't have that variation at all to enroll them into prospective studies related to statin or anti-cholesterol medication.
Yeah, and what you're identifying are these polymorphisms on this gene, this liver-specific transporter, and in a sense, those different polymorphisms affect how statins are distributed throughout the body. Correct?
That is absolutely correct. It's really well described with this specific gene, the SLCO1B1, in adult literature, that it can have a profound impact on how well the statin is actually going to distribute throughout the body, and thereby how effective the medication's going to be. In adult literature, when you have a variation of this specific gene, you have decreased expression of the protein on the surface of the liver. You also decrease the functionality of the transporter as well. So if you're not transporting the medication, like I had said previously, into the liver, there's less drug within the liver to disrupt cholesterol biosynthesis. In adults, when you have this variation, less of the drug makes its way into the liver. The drug levels in the blood are much higher. There's more peripheral exposure of the statin into the muscle tissue and other end organs. And those patients that have that genetic variation are more prone, anywhere from 6 to 16-fold higher increased incidence of myalgia, which is the most common side effect of the statin medications. It also decreases the effectiveness of the drug as well, because less of it's getting where it needs to go. So in adults, that's well described. In pediatrics, it's really unknown. And the challenge is, in a developing child, is that same principle occurring in our patient population. And that's what we really aim to kind of replicate here.
Well, Dr. Wagner, how fascinating is all this, right? I mean, from a pharmacokinetic perspective, right? You know, when we were in medical school, it was really the kinetics were, we thought, mostly influenced by how that drug was formulated. And of course, some of the physiology of the patient played a role, but now we're actually able to look at the genetics of a patient and how that influences drug kinetics. I mean, where do you see this kind of research going in the future, and what do you hope to accomplish?
So I think the frontier is extremely exciting, and I think it can have a profound impact on patient care. There are many of our patients that really read the book in terms of how well they respond to medicines, but there is a segment of our patients that don't respond to medication, or they respond too much and are prone to adverse effects. And it's really trying to capture those patients that are kind of the outside portions of that bell-shaped curve to where pharmacogenetics really comes in. Is there something else that we need to appreciate when prescribing these medications and many other medications to the developing child? And to your point with the pharmacokinetics, I think what we find and what's fascinating is where these medicines are going in the patient. And it's really taking a really hard look at not only the response in the medicine, but what's happening in the whole pharmacokinetic profile. So the absorption,
right.
what's going on there at a transporter level? How is it getting distributed in the body? Is this medication like the statin preferentially going to the brain, which is a very troublesome thing in a developing child that hasn't matured? How is the body getting rid of the medicine? And at every one of those points, pharmacogenomics could have a potential impact. And then you throw in the pediatric population that is developing, and some of these transporters might not even be matured. So is there really an impact of pharmacogenomics in a developing child, a moving target? Well, that's really our passion here at our program. So,
I got to tell you, Dr. Wagner, that's fascinating work, and I know that it's going to reveal a lot of things that we don't know about pharmacokinetics and, as you said, where these drugs are going and how that can influence dosing and side effects. So I want to thank you for the work that you're doing, and thank you for coming on. You're listening to Transformational Pediatrics with Children's Mercy Kansas City. For more information, you go to childrensmercy.org. That's childrensmercy.org. I'm Dr. Mike Smith. Thanks for listening.